Hello again. Our talk here is going to be on late pregnancy bleeding. So this is pretty much bleeding between the late second trimester and delivery. Okay, so about 24 weeks and beyond, 20 weeks and beyond, okay? Just in case you haven't done so already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. Just consider chipping in $1 a month. A little bit goes a long ways, helps keep these videos free. You can get there by clicking on the I in the upper right hand corner of the video, or by clicking on the link that I put down in the description, or you can just type this in. Thank you very much in advance. So we're going to talk about 5 different things here: Abruptio Placentae, Uterine Rupture, Vasa Previa, Placenta Previa, and abnormal placentation. All very, very high yield for the USMLE. Okay. So what do we do if a woman comes in and let's say she's 32 weeks and she says, I've got blood? Okay, she's coming in by ambulance. You know she's coming in. The first thing on your mind is a differential. So there's various places this blood could come from. It may not be from the uterus or placenta, so maybe it's from the cervix. Maybe she has an STD or she's got some cervicitis that makes the cervix more friable and she's bleeding. Or maybe she has polyps. Cervical polyps tend to bleed. Could be that. Or maybe she's got a cervical cancer. The vagina may be lacerated. The vagina gets a little bit more sensitive during pregnancy, and so you may have some lacerations. Or it could be coming from the uterus. Maybe she has a uterine rupture. Or maybe there's something wrong with the placenta. Maybe it's abrupted. Or maybe she has a placenta previa. And with placenta previa, that placenta is right there and can easily become traumatized. Or maybe it's a Vasa Previa. That would be really, really bad to have a bleeding Vasa Previa at home. Or maybe she's sitting on the toilet and she has a hemorrhoid and she notices blood in the toilet and panics and thinks that that's coming from her uterus and not from her rectum. So it could be hemorrhoids. No matter what, when she comes in, the very first thing you're going to do is assess her and make sure that she's stable. No matter what, though, because she's bleeding, even if she's stable, you're going to put in an IV catheter. You want a nice wide bore catheter, so in case she starts bleeding again and it's severe hemorrhage, you want to get saline in her right away. So start a catheter. You can start saline while she's in there because you got the catheter in already. So to start normal saline, you want to put a Foley in as well so you can monitor her urine output. Okay, so you're going to do that right away. You want to make sure the very first thing you're doing is looking at her blood pressure and her heart rate. If her blood pressure is low and her heart rate's high, that's a sign of shock, of volume loss, and you really need to consider some serious options there. You're going to do a speculum examination, and that's to look and see if there's any obvious signs of trauma, like vaginal lacerations or cervical polyps. Then you're going to check fetal well-being, and that can be done, while you're waiting or while the nurse is putting in the catheter. Very easy. Just check fetal heart tones with an external Doppler. Labs. So these labs will make more sense as we talk about these different things. But what you want to do is you want to get a CBC with peripheral smear. That peripheral smear is going to be very important because one of the complications we're going to see is DIC. And so peripheral smear is very helpful in diagnosing that. PT, PTT, D-dimer, fibrinogen. Get a type and cross match. Why do we do that? Because mom might need a blood transfusion if she's bleeding significantly. So you want to know what her type is and you want to have blood on hand and ready. If she's Rh negative, then you want to get a Kleihauer-Betke test. Kleihauer-Betke test tests the level of fetal maternal hemorrhage. By knowing that, then you know how much RhoGAM to give her, because if she's Rh negative, you want to make sure that there's no isoimmunization that will ensue from that. You'll do a transabdominal sonography to look and see where the placenta is, the lie of the fetus, presentation, etc. And if she's before 34 weeks gestation and she's in labor, you want to give tocolytics and betamethasone. The tocolytics give you a little bit more time, extends labor. The betamethasone will do what? It will mature the fetal lungs. Okay, you want to avoid neonatal respiratory distress. That if that baby's coming out, if she's in labor, having contractions, 3 contractions, 4 contractions every 10 minutes, that baby is going to be coming out sooner rather than later. There's something called the app test. This is where you take some of the blood that may be in the vagina, and you can take that and put it with saline and a reagent, and if it turns pink, it's fetal blood. If it's yellow-brown, it's maternal blood. I don't think this is done that much anymore, but I saw it in the literature, and I figured I'd share it with you. Okay, the first thing we're going to talk about is Abruptio Placentae. And all of these things are categorized into painless and painful bleeding. And Abruptio Placentae is not only the #1 cause of painful bleeding, but it's the #1 cause of late pregnancy bleeding overall. So if mom is truly bleeding out her uterus, this is the #1 cause. And this is painful bleeding. Okay, I can't stress that enough. Abruptio Placentae, just think about it, abruption, that sounds painful. So Abruptio Placentae is painful bleeding. The #1 risk factor for Abruptio Placentae is hypertension. Okay, hypertension, the #1 cause, and that can be either pre-existing hypertension, it could be gestational hypertension, it could be hypertension related to severe preeclampsia. No matter what, if there's hypertension, you're at risk for Abruptio Placentae. Blunt force trauma, why? Because you can avulse the placenta. Cocaine use because of vasoconstriction, and then previous abruption. If she's had one abruption before, she's at risk for another one. Symptoms, painful late pregnancy bleeding. This is painful bleeding. There's other types of bleeding that can happen similar to this, where it's painless. This is painful bleeding. Okay, so if you feel mom's uterus, it's going to be firm, but it's also going to be tender. She's not going to want you to press it. Okay, very tender uterus and firm. Okay, painful late pregnancy bleeding. The pain will be present between contractions. So normally if mom's in labor, and this is assuming she has contractions, but normally if mom's in labor, she doesn't have Abruptio Placentae, there's going to be significant pain during the contractions. And then the contractions subside and the pain subsides. Then she has a contraction and the pain comes back. With Abruptio Placentae, she's going to have pain during the contractions and after the contractions. It's going to remain because the placenta has abrupted, and that is painful. Okay, so pain present between contractions. If you check the fetal heart strip, so you have her hooked up to cardiotachometry, you'll note if there's significant bleeding, okay, and there's not always a ton of bleeding, there's different degrees of placental abruption, but if there's significant bleeding and the baby's losing blood, you'll see bradycardia and late decelerations. Late decelerations, because this is a placental problem. Placental problems give you late decelerations, okay, because it's fetal blood loss. It's not going to be variable decelerations because it's not affecting the umbilical cord. Okay, these are late decelerations. So very gradual dips that start after the contraction starts and ends after the contraction ends. This is difficult to pick up on sono, but you still do a sono anyway to rule out Vasa Previa. Okay, especially if you're having these decelerations and stuff. Vasa Previa, though, it's not really, I mean, you'll know Vasa Previa if it happens because the blood is brighter and usually it happens in association with rupture of membranes. This is what I read in the literature. Take it for what it's worth. Management. So this goes pretty much for anything. If there's maternal or fetal jeopardy, it's C-section. Okay, emergent C-section. You want to stabilize mom as much as you can. There's not much you can do for the baby other than try to get it out. Okay, so maternal fetal jeopardy, emergent C-section. If she's term and she's stable, so her blood pressure's good, her heart rate's good, and she's term 36, 37, 38 weeks or beyond, then you can do a vaginal delivery. Okay, remember, when does the placenta normally abrupt? The placenta abrupts normally, right? It abrupts in the 3rd stage of labor. After the baby's delivered, you clamp the umbilical cord, you cut the umbilical cord, you've got the clamp on the umbilical cord, and you wait, and eventually you get that gush of blood. That's the placenta abrupting. That's why you get blood from Abruptio Placentae in most cases. Well, if the placenta is already abrupted and she's term and you've got a nice, cephalic presentation and everything, you can do a vaginal delivery. If she's preterm and stable, you're going to admit her and observe. And then depending on how bad the abruption is, if it's bad enough, eventually that baby's going to come out. If it's just a mild abruption, she may actually be able to go home. but it really just depends. Okay, so there's different ways you can have placental abruption. The most common is this one here, the partial separation. So the partial separation is where you have on one or on both sides, the placenta has abrupted from the uterine wall. And so you're going to have bleeding, and it's going to come right out. And it's going to come out the cervix, and mom's going to say, I've got bleeding. Okay, or you can have a partial separation. And the partial separation and a complete separation, they just vary on their degree. But in either case, you have abruption in the middle, and the sides of the placenta are intact. And so you're going to have bleeding in between the uterine wall and the placenta, but it's not going to be able to get out because you're attached on both sides. Okay, so there's no way that this blood's going to get out. This is a little bit less common. The partial separation and complete separation only make up about 20% of placental abruptions. And this is actually, you would think that this is less dangerous, right? Because the blood is kind of contained. Actually, it's not. This is more dangerous to the baby because you can develop clots in there, and those clots can then come to the fetus, and they're called retroplacental clots, and those can actually, that can cause the baby to die. Okay, so you'd rather have partial separation, if anything. Okay, you'd rather not have abruptio placenta at all, really. Okay, next topic. Sorry, complications. Okay, this is big. So abruptio placenta, you're going to want to know this for the USMLE. Mom comes in, she's 32 weeks pregnant. She's you do blood tests, she's bleeding, you do blood tests, and she's got low platelet count, prolonged PT, PTT. What's that a picture of normally? Well, that's a picture of DIC, low platelet count, prolonged PT and PTT. Why is it prolonged? PT and PTT, is it prolonged because of the low platelet count? No. Low platelet count will increase your bleeding time. Why do you have prolonged PT and PTT with DIC? Because you're consuming factor. So you're consuming factor, you get a prolonged PT and PTT. Why do you have thrombocytopenia? Because all those platelets are sticking together, and the machine counts, it doesn't count individual platelets, it counts pieces of platelets. And so because you have all those platelets sticking together, it reads it as a low platelet count. Okay, so you have thrombocytopenia. Why the schistocytes and helmet cells? Well, because you have platelets that get blocked up in the capillaries, and when the blood cells come by, it fragments the red blood cells, and it causes these red blood cells to become deformed. Little pieces get knocked off, and you get these schistocytes and helmet cells. I didn't put in a picture of that for you, but you can look it up. D-dimer is going to be high, and then fibrinogen will be low to normal. Fibrinogen is not a really good way of diagnosing DIC. DIC, you're going to diagnose it based on the thrombocytopenia, the schistocytes, and the PT, PTT being prolonged. D-dimer is helpful, though, too. Preterm delivery, obviously, if the placenta is abrupted enough, that baby's going to have to come out because the placenta is no longer going to be sufficient or adequate to oxygenate the baby, and so the baby's going to need to come out, and what's mostly going to tell you that is fetal distress. Maternal and or fetal shock. Well, obviously mom's bleeding, so she can have shock, or baby's not getting blood from mom through the placenta, so baby can go into shock. Okay? Mom being in shock will be a tachycardia and a hypotension. Baby going into shock is going to be late decelerations and bradycardia, which you'll see on cardiotocometry. One of the complications of maternal shock is decreased perfusion to the kidneys, which is going to result in renal failure. So that's a complication of maternal shock. That's a complication of shock for anyone, though. The death rate, it's much higher for baby than mom, and the reason is because if baby has only about 300, 400, 500 milliliters of blood total. So if baby loses 150 milliliters of blood, that would be akin to you losing 2.5 liters of blood. Okay, not going to be good. Okay, so baby's death rate is 35 to 80%, and it just depends on the severity and how quickly they get care. Mom can tolerate it a little bit more. If mom loses 300, 400, 500 milliliters of blood, she's fine. How much blood does a pregnant woman have? 7 liters. Okay, so mom can typically tolerate this pretty good. Her death rate's rather low. Okay, uterine rupture. So we talked about uterine rupture and some of the complications of labor and delivery, but I want to talk about it here because this is a cause of bleeding, late pregnancy bleeding. The uterine rupture is complete separation of the wall of the uterus. Okay, the uterus is bursting. It's separating. Most commonly, it's associated with uterine scarring from a classical cesarean incision. So way back in the olden days, they used to take the uterus when they did a C-section and cut it up and down, vertically. We don't do that anymore because of the risk of uterine rupture. Now we go at the bottom of the uterus and make a longitudinal incision called the phalansteal incision, or a low transverse incision. And the reason we do that is because there's less risk of uterine rupture. Now, why would a woman have a vertical incision? We haven't done that in a long time. We haven't done that routinely in decades. Well, if a woman has a baby that's breech, some obstetricians will do a vertical incision. Or if you have a multiple gestation and you need to get multiple babies out, a vertical incision is a little bit easier to get those babies out. So there are indications for vertical incision. You want to know, though, on her OB history, what kind of incision did she have if she's had a cesarean section. Risk factors: uterine scarring. That can be from C-sections, as we just talked about. It can be from trauma. It can be from instrumentation. If she's had a D&E with an elective abortion, that's going to increase her risk of uterine rupture. History of myomectomy. Taking out stuff from the uterus, which is myometrium. If you're taking some of that out, that's going to reduce the integrity of the uterus. Excessive uterine stimulation. If you're inducing labor, you're giving Pitocin, you give too much, you can cause the uterus to be hyperstimulated. That increases the risk of uterine rupture because the pressure goes up. Uterine anomalies, history of invasive molar pregnancy. Again, it's invading, it reduces the integrity of the uterus. History of placenta precreta and increta, which we're going to talk about last. Malpresentation, fetal anomaly, and cocaine abuse. Symptoms. So this really depends on when it's presenting. If mom's coming in from home and she's had a uterine rupture, she's going to have severe pain because she hasn't gotten anesthesia. If she's had a spinal or an epidural, she's not going to feel so much. And so is this tearing uterine pain and popping sensation going to be really helpful? No. Okay, so you have to know whether she's had anesthesia. If she hasn't had anesthesia, if she's had anesthesia, you can't rely on her telling you that she's got pain. You're going to more so have to rely on fetal distress. So the tearing uterine pain, of course, is happening because you have the uterine rupture. The popping sensation is happening because there's a significant pressure within the uterus, and once the uterus ruptures, that pressure is relieved and she feels a popping sensation. This is a painful late pregnancy bleeding. Well, think about it. If something ruptures inside of you, that sounds like it's going to hurt, and this does hurt. So this is painful late pregnancy bleeding. One of the things that you can see on with uterine rupture, if you have tochometry going, is that the contractions might stop, or they may become abnormal, where they become weaker and more frequent. You're only going to notice this on, well, if mom hasn't had anesthesia, she might be able to tell you, but tochometry is going to be the best way to notice this. So you'll see lower amplitude contractions and more frequent, or contractions just stop altogether. Another thing you can see is a loss of fetal station. So baby might be at 0 station, fully engaged, and the uterus ruptures and now the baby is -2 station. Okay, no longer engaged. Baby should never be going backwards. Okay, they should always be going forwards. So a loss of fetal station is consistent with uterine rupture. However, the most reliable sign of uterine rupture is fetal distress. Okay, so mom's bleeding, less blood going to the baby, going to get bradycardia and late decels. If you ever, whatsoever, suspect uterine rupture, it's an emergent C-section. Not only because you need to get that baby out, but because you need to repair the uterus. Okay, so you're going to repair the uterus, or you're going to do a hysterectomy. If mom doesn't want to have any more babies, and this is why it's good to know in advance, if mom doesn't want to have any more babies, just go to a cesarean hysterectomy and get it done with. Okay? All right, Vasa Previa. Now, Vasa Previa is rare, but it's commonly tested on the USMLE because if you don't detect it soon enough, the baby will die. Okay, so this is a very rare condition in which the fetal placental vessels cross the internal cervical os. Okay, so there's a couple ways that this can happen. Number one, the vessels so normally those vessels all come together on the placenta and then they come up into the umbilical cord. Okay, but another way that this can happen is that the vessels converge away from the placenta and then go into the umbilical cord, as it's happening here. They're converging away from the placenta, then going into the umbilical cord. That's bad, because if the vessels are converging away from the placenta, you don't have any protection, and that vessel is now exposed. Another way that this can happen is you have the placenta here, but then you have another little piece of placenta. Okay, this is called a succenturiate lobe. And this succenturiate lobe is going to be connected to the main placenta by vessels. And if those vessels are at the cervix, this can be a big problem. Either way, if you do artificial rupture of membranes where you're taking a little sharp tool and trying to rupture the membranes, and you don't know that there's a Vasa Previa, you don't know that there's a vessel going across the internal cervical os, you can rupture that vessel very easily. And whose blood is this? Is this mom's or is this baby's? It's baby's blood. This is fetal blood. You're going to see bright red blood coming out, and you are going to freak out because this baby has minutes to live. This baby needs to be delivered by emergency section. Okay, so this is a succenturiate placenta. So you see the main placenta here, and you know it's the main placenta because this is the umbilical cord coming in with all the vessels. But then you have this little mini-me placenta, and this is called the succenturiate lobe. It's also placenta, it also has vessels, and it's connected to the main placenta by these vessels. And if these vessels are sitting at the internal cervical os, they can become ruptured by rupture of membranes. This is a velamentous cord. So remember where the vessels converge outside of the placenta? Normally they should converge down here and then go into the umbilical cord. Here they converge up here. So what's happening is the blood vessels are inserting in between the chorion and amnion, and this is away from the margin of the placenta, and so you have no protection here, and so it exposes these vessels to injury. This is a velamentous cord. So the risk factors are velamentous cord, succenturiate lobe, and multiple gestation. This can easily be diagnosed by sonography. So this is why we're always doing sonography before mom is going to deliver. We want to know where, not only where the baby's at, what's the lie, but also we want to know if there's any abnormalities with the placenta or with the umbilical cord. So you'll easily be able to diagnose this because when you get the color Doppler, you're looking for blood flow, you'll be able to see at the internal cervical os if there's anything crossing that. I didn't put any pictures up, and I wish I did, but you can look up ultrasound of Vasa Previa, and you'll be able to see at the cervical os there's a vessel going across, and that is Vasa Previa. So the way this presents is mom comes in, you don't know she has Vasa Previa, you do an artificial rupture of membranes, you rupture that vessel, and now there's bright red, painless bleeding. Why is it painless? Well, there's no nerves in the placenta, so you're not going to feel it. But it's bright red blood. That's important too because that's oxygenated fetal blood. And then right away, baby's going to go into bradycardia because the baby is losing blood quickly. Management, emergency section, as quickly as possible. We're talking you got minutes, so you need to get her in quickly. Complications, fetal death due to exsanguination. Unfortunately, this is all too common. It's very difficult to save a baby with Vasa Previa rupture. Okay, Placenta Previa. Very commonly tested, very common in real life. So Placenta Previa is a common condition which the placenta lies in the lower segment of the uterus. Now, the upper segment of the uterus is very good at stretching, okay, and the placenta can easily stretch with it. Lower segment, not so much. Okay, the lower segment of the uterus, when it stretches, it's going to pull on the placenta. And as it pulls on the placenta, it can avulse the placenta from the uterine wall. And when that happens, you can get bleeding. Very somewhat similar to with the placental abruption. So normally, if you look at a woman on ultrasound at 24, 25, 26 weeks even, and you look, or even before that, but if you look at where the placenta is, it might be quite low. Okay, we want the placenta to be up at the top, a fundal placenta, or anterior or posterior, but somewhere towards the top. But it might be low. That doesn't mean she's going to have a placenta previa and that she's got to have a C-section. What can happen, and what does happen, is that the placenta will kind of atrophy towards the bottom, and hypertrophy towards the top. So the placenta is migrating upwards. And this normally happens during the course of the pregnancy, but if it does not happen, the placenta is going to remain down in the lower segment, and that is a placenta previa. So there's three different types of placenta previa. There's a marginal placenta previa, where it's in the lower segment, but it's not touching the cervical os. There's a partial placenta previa, and that's where the placenta is partially covering the cervical os, but not completely. And then there's the complete placenta previa, in which the placenta is completely covering the cervical os. Which one of these do you think needs C-section? Partial and complete. With a marginal, if it's more than 2 centimeters away, you can get by with a vaginal delivery. And the risk factors for, actually, you know what, let's look at this real quick since we just talked about it. So this is a marginal placenta previa. The placenta is in the lower segment, but it's not touching the cervical os. This is a cervical os down here, the internal cervical os. This is a partial placenta previa, where there's some cervical os that is patent, but there's some covering of the cervical os by the placenta. And then this is a total placenta previa, in which you have placenta that's completely covering the cervical os. The risk factor for placenta previa is previously having a placenta previa, multiple gestation because you have multiple placentas, and so one of those is probably going to be in the lower segment. And then artificial reproductive techniques. Here we're talking about in vitro fertilization. If you understand how in vitro fertilization is done, it makes sense. So you take that zygote and you're putting it in a catheter and you're putting it up the cervix. Okay, now normally when you have fertilization, it happens in the fallopian tubes, and the embryo is going to come in to the uterus at the top. With in vitro, it's coming in through the bottom, and so you have a higher likelihood of implantation in the bottom, and so that placenta is going to be more likely to develop towards the bottom, and so you have an increased risk of placenta previa. The presentation of placenta previa is painless uterine bleeding. So something could happen, for instance, where you have let's say a total placenta previa, and the mother is having intercourse, and there's trauma to the placenta. That would cause painless uterine bleeding because the blood is coming from the placenta. And so this is painless uterine bleeding. This is diagnosed on sonography. Okay, it's very easy to diagnose on sonography, and since we're getting sonography frequently as mom's coming in for her third trimester visits, this is not so much a problem. We can diagnose this before any complications arise usually. Okay, so the management is to not do a vaginal exam. You can avoid a lot of complications if you don't stick your fingers in the vagina when there's a total placenta previa. Okay, so you don't want to do a vaginal exam because you can cause separation of the placenta, and you don't want to do that. So what you have to ask yourself if you have bleeding, and this is always something you ask yourself, is mom or baby in jeopardy? If the answer is yes, it's an emergent C-section. So if mom is hypotensive, tachycardic, C-section. If you got late decelerations, C-section. If you have sustained bradycardia, C-section. The next thing you ask yourself, is mom and baby term? Okay, if they are term, then you want to know where the placenta is at, and this is why you get a sono. If the os, and this should actually say marginal placenta, but if the distance between the placenta and the os is more than 2 centimeters, you can do a vaginal delivery. It's safe to do a vaginal delivery. If it's less than 2 centimeters, then you need to schedule a C-section. You don't have to do it right away, but you need to schedule a C-section. If she's preterm and stable, you're going to admit and observe. You may even be able to send her home, but if you do send her home, you need to tell her to be very careful and absolutely no intercourse. You're going to deliver at 36 weeks. Complications: preterm delivery, preterm premature rupture of membranes, intrauterine growth retardation, male presentation, Vasa Previa. Well, because you've got vessels of placenta that are going to be on the os, so Vasa Previa is a risk. Congenital anomalies. So male presentation. Why a risk of male presentation? With placenta previa, in a lot of cases, you see a transverse lie. Why might that be? Well, the fact is, with one of the risk factors for placenta previa is congenital uterine anomalies, because the placenta may have a hard time implanting on the fundus if you've got some big whopping uterine septum. So, because of that, you're at risk with congenital uterine anomalies to have placenta previa. Well, it also happens that if you have congenital uterine anomalies, you have a risk of malpresentation. And so it's those two or those three that are correlated together. That's why indirectly placenta previa is often seen with malpresentation, because there is oftentimes some kind of congenital uterine anomaly. Okay, so you do a sono, and this may come up on the test. I wouldn't put it past them. This would be a hard question because not everyone gets real familiar with these sonos. So the first thing you ask yourself is where's the placenta or where's the cervix? But you need to know both. So where's the cervix? So the cervix is this little canal, and it's right here. Okay, so the cervix is right here. Okay, this is one wall of the cervix, this is another, and this is the canal. Where's the placenta? So the placenta is going to look a little bit more echogenic than the rest of the tissue. It's going to be a little bit whiter. This is the placenta right here. You can see the margins of the placenta. And so you want to measure with your calipers the distance between the cervical os and the placenta. And if it's more than 2 centimeters, that's good. If it's less, that means C-section. Okay, so again here, so this is, by the way, a low-lying placenta. Okay, so you have here. All right, next one here. Okay, so this is, this is already given to you. This is kind of nice. So this is the cervix here, the dotted line, and this is the placenta down here. What's this? This looks like it might be skull. There's a placenta here, cervical os. You're partially covering the cervix. Okay, so the cervix starts right here, ends right here. You got some partial covering of the cervix. This is a partial placenta previa. Okay, marginal placenta, partial. Okay, what about this? Where's the cervix? And you know where the placenta is. It's telling you. Where's the cervix? Right here. Okay, here's your cervical canal. Here's the cervix. Placenta totally covering it. This is a complete placenta previa. All right. So this mom is getting a C-section without a doubt. And this one's kind of cool. I found this online. So what do you have here? Where's your cervix? Right here. Where's the placenta? Coming down right here along the side. And it's covering the cervical os. I can't tell. You'd probably have to see another dimension in order to see if this is complete, but I do believe I read that this is a complete. Okay. So, and then you see here the fetal skull, and it looks like, it's hard to see, you have to look at another dimension. This looks like it's cephalic presentation. Okay, I think this is the rest of the body up here. You got legs here. Okay, abnormal placentation. So this is a complication of placenta previa in the presence of a previous uterine scar. Why is this a complication of placenta previa? Well, where does that scar often happen? Down here. We do that low transverse incision. And so because you do an incision down there, you're disrupting the uterine wall. And so what happens is, because of that disruption, you have a formation of scar tissue at the decidua basalis. And so that scar tissue developed. But scar tissue, in general, and this goes for any time you form a scar tissue is weaker than the tissue it's replacing. And so as the placental villi invade during implantation, it can actually penetrate that scar layer, and it can continue going. So normally, the placental villi will invade and it will stop at the superficial layer of the decidua basalis. If you have scar tissue, this tissue is called Nittebuch's layer, and that layer is weaker than normal tissue. And so it can actually go beyond that. And if it does go beyond that, the placenta villi go beyond Nittebuch's layer, the scar, that is called a placenta accreta. Okay, placenta accreta is where you are invading the deep layers of the decidua basalis. and this is the majority of abnormal placentations. However, if you continue going and you go into the myometrium, then it's a placenta increta. Okay, a placenta increta, you're partially going into the myometrium, not all the way through the myometrium, but partially going into the myometrium. And then a placenta percreta is where you go all the way through the myometrium and possibly even to the serosa or even outside the uterus, and you can actually go to a structure that's very close to the uterus, the bladder, and you can actually even go into that and invade the detrusor muscle of the bladder, and that would be a really, really bad deal. Okay, so accreta, increta, percreta. The major risk factor, previous uterine scar. And this coincides with placenta previa because it's got to be low, because that's where the scar is. 2/3 of patients will require a cesarean hysterectomy. Now, why is this such a big deal? Well, because it's very difficult for the placenta to separate spontaneously when it's so deep. Normally, the placenta is just, maybe a centimeter in. I'm not exactly sure how far, but it's not very far into the uterine wall, and so it's easier for it to separate during the 3rd stage of labor. If you're too deep, though, you're anchored too far in, and that placenta, it's going to be very hard for it to separate. But you'll have bleeding, though, because the placenta will die off after delivery when the uterus contracts, and so you can get some major bleeding. But even if you try to remove it, like during a C-section, it's going to be very difficult to remove the placenta. So what typically happens when you have a placenta accreta, increta, or percreta is that you'll do a cesarean delivery and then you're just going to take the uterus out, placenta and all. You're not even going to try to get the placenta out. Okay, the average blood loss during one of these procedures, I believe, I'm not sure if it's when you're trying to take the placenta out or just in general, but the average blood loss is 3 to 5 liters. So these women are going to need blood transfusions. Okay. If it's just a very minor accreta, you may actually be able to get the placenta out, but it really just depends. Okay. These are varying severities here. You can diagnose this with sonography. Okay, so you'll use your Doppler and you'll be able to see the vessels and how far they're penetrating into the uterine wall. The maternal death rate with abnormal placentation, it's going to be higher, obviously, if there's, depending on whether you do a hysterectomy and how much blood loss there is, but it can be as high as 7%. So this is not something to shake a stick at by any means. Now, interestingly, back in the 1980s, the incidence of placenta accreta was 0.8 out of 1,000. A very, very, very small number. That's 80 per 10,000. It's not, sorry, 8 per 10,000. That's not very much. That's only 800 per million. Today, it's 3 per 1,000. So the incidence has gone up 4 times. Why do you think that is? Because we're doing so many damn C-sections. They're too much. Now, a lot of people say that it should be at mom's discretion, and I agree. I'm not going to be the one to challenge a woman. But you really got to think, the C-section is not just some mundane, inconsequential procedure. You're going to have uterine scarring. And if you have another baby, you're going to be at risk of having abnormal placentation, among other things. Okay, so it's a complication of C-sections. Okay, so normal accreta going through the deep layer of the decidua basalis, increta going into the myometrium, and percreta going through the myometrium and beyond. So summary, I put the type of bleeding, painful or painless, the blood, whether it's maternal or fetal, how it's diagnosed, typically what's going to help tell you, and then the complications. So abruptio placenta, painful bleeding, comes from mom. You're going to note it on sonography, may help you, but it's going to be the fetal heart tracings that help you the most to help you determine to what degree of severity this is and whether there needs to be a delivery. Complications, DIC is the big one. Uterine rupture, painful, There'll be loss of station, change of uterine contraction pattern, fetal heart tones, you get some late decelerations. Complications, you may need to do a hysterectomy if you can't repair the uterus. But this is going to be a C-section. Placenta previa, painless bleeding because it's coming directly from the placenta. The blood is maternal. Diagnosis is sonography and fetal heart tracings. Complications, one of them is malpresentation. Vasa previa, this is the worst thing you could possibly have out of all of these. It's going to be fetal blood, bright red blood, and you'll note fetal heart tones, you get severe bradycardia as well as late decels. And this is a high risk of fetal death. Abnormal placentation, we just talked about, diagnosed on sono. Most of these women get hysterectomies by cesarean. And all of these have the complication of preterm delivery and fetal death. Preterm delivery because in many cases you're going to have to get the baby out, and fetal death because of blood loss. Okay, so let's play a game. Major risk factors. I tell you a risk factor, you tell me what it is. Uterine scarring. Uterine scarring is a risk factor for abnormal placentation, accreta, increta, percreta. Multiple gestation, artificial reproductive techniques, i.e. in vitro. Placenta previa. Okay, the zygote's not getting far enough up, placenta develops too low. Classical incision and uterine overstimulation. Uterine rupture. Multiple gestation, succenturiate lobe, and filamentous cord. This is an obvious one. Vasa previa. And then the last one, hypertension and trauma. And we'll put in cocaine use too. What is this? Abruptio placenta, the #1 cause of late pregnancy bleeding. And that is all I've got for you. If you have any questions, write me a note below. Otherwise, I will see you next time.